Zach, take it away, my friend.
Thank you for the kind introduction. Yes, as Subhash said, I'm in Dallas, downtown at Baylor Heart and Vascular Hospital. Now I'm lucky to call him my partner. So we're going to talk about an interesting case here of a stent fracture. While technically may not be the most interesting or most challenging, I think intellectually it's really important, brings out some good teaching points, and that's what I'm going to try to highlight as we go through this. So, I don't have any relevant disclosures, just set the background. This is a 37-year-old woman who has very aggressive polyvascular disease. She's had multiple coronary stents, had an ischemic cardiomyopathy. Her EF has improved. She had critical limb ischemia, for which she underwent a prior intervention. I'll show you those images in just a second. She had a long segment SFA CTO that was stented. You can see her other risk factors here and her medications. She healed that wound 2 years prior and then presented again with a DVT, acute DVT of the left lower extremity, which was noted to be at a site in the distal SFA near her stent. And so we'll move forward here. Here's her prior interventions done back in 2021. Long segment SFA CTO was crossed, flow limiting dissections prompting stenting, and final results on the far right. So here's where we're at now, okay? So that DVT, under further evaluation, we got an arterial duplex ultrasound, which revealed concern for an aneurysm and clear stent fracture. So we brought her in because she also developed significant claudication at this point in time. I don't have her ABI because her tibial vessels are non-compressible, so everything we were doing is based off the arterial duplex. You can see here in the mid segment of that stent, there's a large aneurysm, okay? She has outflow, and then a zoomed-in angiogram picture here showing multiple type 4 stent fractures with complete disarticulation of those self-expanding stents. Here's her CT scan as well, okay? Let that run. So what's the difficulty here? Well, she has claudication, okay, so she does have a stable disease process, but lifestyle limiting. This is right at the site of where her acute DVT was as well, so we do think that this is probably what led to her having her acute DVT. We tried to have her do a walking therapy. She did not have any significant improvement, and because of her borderline ejection fraction, we didn't feel Solosazole was safe, so we felt moving forward with an endovascular intervention was probably in her best interest. We did discuss this with our surgical colleagues about a potential bypass of this. They were not keen on potentially ligating her artery or bypassing because of her body habitus, and she did not have great veins as well, so they were concerned about the long-term patency of that. So we decided to move forward with an endovascular approach. So things that I think are important to consider in these types of cases are, one, you've got a large filling defect, so you need to cross that without hopefully damaging the aneurysm further, okay? We don't know how that stent is going to respond when we are trying to treat that, so we need to make sure that we balloon it and that those stent struts are not going to inhibit us expanding a new stent or whatever scaffold we put in. Do we have to reinforce this? Okay, are those stent struts going to still impinge whatever stent that we put in, and how are we going to reinforce that? Are we going to do that first? Should we do that second? And then should we reconsider surgery again? So again, we decided to do this endovascularly after we discussed with our vascular colleagues, and our thought was to try to cross this antegrade. We have retrograde access prepped if needed. We were going to try to dilate this 1-to-1 to ensure that the stent was going to expand and behave appropriately for us to put a covered stent in. IVUS is non-negotiable in these cases for sizing, okay, because we need to make sure we have adequate stent apposition, and then a post-IVUS as well to make sure that those areas where we had disarticulation, that we have good extent expansion, that we don't need to reinforce those areas. So we'll move through this. Just some angiograms here. So we use a straight wire initially, okay? That straight wire wanted to keep getting into the aneurysmal spaces, even with using a Navicross catheter. So we used a J wire. This is actually a Rosen. That loop wire liked to stay more in the true central portion of the artery, which allowed us to cross safely. We did not have to use retrograde access in order to rendezvous. So we get through, we IVUS. This is this stent. It was a 6-millimeter vessel, so we use a 1-to-1 balloon. You can see, thankfully, that balloon has good expansion in the disarticulation space. And here's the IVUS still frame image on the right. So now we decided to oversize our stent by 1, so we used a 7mm stent. Important also, because we couldn't tell exactly where those aneurysms started and stopped, take enough stent length, okay? So you have good seal proximally and distally. So we took a 7x150 Viabond stent. Be careful when you deploy this because you have all these edges. You don't know how the stent's going to respond, so don't rush and just rip the string back as you deploy these. Do it slowly to make sure that you're not catching that stent anywhere. And then post-dilate as well. And here's our final result in our IVUS image on the right side showing good stent expansion. That's at the disarticulation zone. So just to highlight some of those teaching points, again, crossing can be sometimes challenging with these J-wires and directional catheters to stay true lumen. IVUS is non-negotiable. You want to ensure that those areas are going to dilate appropriately. Covered stents, oversized with length and diameter, and then post-IVUS as well. If you do have to reinforce these, probably best to use a shorter supera stent inside the Viabond rather than putting a supera stent initially, because a supera stent, as everybody knows, deploying can sometimes be difficult anyway, and in those jagged and tortuous portions of the stent where the stents are disarticulated, there's a lot of risk that you just don't get that supera expanded well there. So at least if you put the Viabond in first and then have to reinforce in those areas, it's probably a safer way to do so.
That's all I have. Thank you so much. Let me introduce our panel, and we try to do this a little bit differently, but anytime we do something different, there are some obstacles that you learn. So we don't have a good monitor yet, at least today. Hopefully by tomorrow we'll fix it. So our panel is sitting here, Dr. Metzger, everybody knows Dr. Chris Metzger, Dr. Peter Monteleone, everybody knows him, Dr. Jun Li, everybody knows her, and Dr. Ben Colvard. Ben, we just invited you to be on the panel. And Dr. Eidt, that's right, and we have Dr. Eidt. Wonderful. So we're going to use that table as our panelist. We have 2 minutes left, 50 seconds left. I have a couple questions, just some tips for our audience. If you have a 6mm stent and you have a situation like this where you have a, let's say, aneurysm or perforation, what size Viabond should you put in a 6mm stent? Chris Metzger. Please turn. There is a little button you have to push up.
All right, let's try again. All right, thanks, Mehdi. I think, to me, it depends more on the distal ends of that than the stent. So the IVUS showed it, conservatively, it was at least 6. I think it was 6.3, 6.4. So I think the 7 was the right choice. You want to not be more than 20% over the native artery. You're covering aneurysms as well. So I would go, I think the 7 was the perfect choice. And then you can post-dilate it with impunity because you're inside a covered stent if you want to put a supera stent in. Right.
But you don't want to go too big because then you get the enfolding with the Viabond, and that's where you get into trouble.
Completely, but you still are covering aneurysms as well. And so I think that was at least a 6.0 nitinol. I think the 7 was still the right choice.
Okay, let me ask Peter one question quickly. How about if you have a stent fracture, and this is a stent fracture talk, and you want to cover it with a supera, and you have a 6mm stent previously, now you have a fracture, you ballooned it, you're getting recoil, and you want to put a supera inside of a 6mm stent. What size supera would you recommend? I'm asking the tough questions. I'm sorry, guys.
Well, and you're also asking next to someone who knows more about how supera stents behave than ever. There's the same concept about the fact that you're not just treating a vessel, you're treating that pathology of the stent fracture. And so the concerns for kind of undersizing what you're doing kind of creates that scenario. I probably would try to size it still 1-to-1 to that distal edge. I don't know, Chris, would you go bigger?
I think you're going 1-to-1, and I think I would go 6.5, somewhere in there, because you get too big, it's going to start to elongate, and then you lose it. And you've already got a club sandwich in there. You've got a triple stent layer. You don't want to elongate this.
Yep. And like we've seen, overexpanded and underspanded supera stents by length, you lose all the benefit that comes out both for patency as well as the woven benefits for flexibility.
Okay, great. So we said Viabond maybe 1mm larger than the stent that's there, and supera maybe half. But you got to make sure you have good vessel prep and that you have dealt with that fracture site so that it doesn't recoil. Dr. Ansel?
So one of the other considerations you have to say is, why did this occur? Because this is uncommon. I've seen 3 in my career. So what I would have actually also done, just because of that knowledge, is I would have done a bent leg angiogram to see if there's an area that I'm still going to have crushing, because superiorus resists fracture, but I don't know if anybody's ever seen somebody who sent them to them with a popliteal entrapment. They just shatter as well. So you really want to understand why that was occurring in the first place, and making sure sometimes you got to double treat the area where you're really getting a kink.
That's a great point. Like, why are you getting that fracture? Why are we getting the fracture in the site that you're getting it? So understanding the pathology. Thank you. Okay, I wish we had another 20 minutes because there's so many things to ask, but for the sake of time, with your permission, I'm going to move forward. The next talk is radial to peripheral, what's possible, with Dr. Sameh Sayfo from Baylor Plano. Thank you.
Thank you for having me. Can we have a slide up? So we're the other sister of Baylor downtown, with a stepsister. Anyway, so I think the radial to coronary has been a hot topic for almost 10, 15 years. Oh, thank you. The radial to coronary has been a hot topic for a long period of time. And if you guys remember, 10 years ago when radial came to coronary, a lot of operators said, hey, I've been doing femoral for a long, long time. What would I change? And we learned less bleeding, the same success rate, and some benefits. So now I think we're at the same age, the same era for the radial to peripheral. This is my disclosures. So this is a 75-year-old gentleman who came to us for a worsening claudication, life-limiting claudication, Rutherford 3. He had a history of PAD, hypertension, coronary artery disease. He actually has a known left external iliac and a common iliac occlusion. 10 years ago, he had a fem that lasted for 6 years, required another operation 4 years ago, requiring another fem. And he did well for a while. 6 months ago, he started having the same symptoms, and he came to us for evaluation. We usually send our patient for a supervised exercise program, and he tried to attend it. He only was able to do 10 sessions, but he really couldn't finish any of them completely because of the severe pain. So his resting ABI on the right side is a 0.4, on the left side was 0.92, that's resting ABI. And when we did a CT scan, we showed an occlusion of the ostium of the SFA, possibly versus the distal common femoral on the right side, the distal to the anastomosis of the fem bypass. He had also what's shown, we know, is the left external iliac and common iliac occlusion. So the clinical challenge here is what treatment option we have for this patient. We can send him for surgery to do a distal common femoral ostial SFA surgical intervention. We can do pedal access, or we can try radial to peripheral. So this is our selective imaging. You can see the fem is open. The left side has a good flow. We did a full run, and there was no disease on the left side. But you see this is a short occlusion in the right distal common femoral ostial SFA. So step-by-step for intervention, we used a somatic 120 centimeter radial to peripheral sheath that landed close to the external iliac. We used a Navicross 018 150 centimeter support catheter, and we're able to cross it. Actually, our endovascular fellow was able to cross it with an 018 command wire. We couldn't pass the microcatheter, so we pre-ballooned with a 2.0 balloon. Then we crossed the microcatheter and we switched to a Viper 475 wire. Our plan is, because of how heavily calcified, we need to do some calcium modification. We measured the length, and we had two options here. Either we do a lithotripsy or a CSI. Actually, the lithotripsy balloon did not reach, even the M5 plus 135. So we proceeded with orbital atherectomy, and we did the 1.75 burr and a 180 shaft. And what we did is we crossed distal to the fem bypass takeoff, and actually we crossed through the lesion, or just close to the lesion, and we were very carefully, we delivered multiple runs. And we we perform more IVUS than traditionally used across the country, but when we have a challenging case or something that we don't understand, we like to do IVUS. We did IVUS, and what we noticed actually proximal to the takeoff of the fem-fem bypass, there was a napkin ring stenosis as well. So we went back and did another run of the orbital atherectomy at that location. Then we proceeded with the 7x40 balloon. You see nice expansion there. And then we debated if we should just stop there, or we're trying to avoid putting any balloon across the fem-fem takeoff. But because of this lesion, we proceeded with a 6.0 DCB, and we had a less than 20% residual. This is our pre, and this is our post. And we did a pullback gradient there, which was only 5 millimeter mercury. So the topic here is what's possible and what's not possible from radial to peripheral. So what's possible from the experience we've seen across the country is you can do different anatomy. You can do iliac, you can do femoral popliteal, you can do common femoral, and you can do upper extremity very easily by radial to peripheral technology that we have available. Morphology, we can do heavily calcified lesion. We've done CTO, SFA. Combined radial to pedal axis has been very helpful instead of doing another groin axis, just to lower the risk of bleeding. Calcium modification, the two options that we have available right now is orbital atherectomy and lithotripsy. Other companies are working on extending the length of their devices, so we'll see what that brings up. Drug coating balloon, we have two options. The only one that's 200 is made from Medtronic, but hopefully we can get it. IVUS kind of reach around the proximal part of the SFA. What's not possible, and I think this is not a true statement, we select not to use radial to peripheral nowadays just because we have more equipment and technology in the femoral space, the common femoral axis space, but I think it can be done, is anatomy, for example, below the knee limitation, but some of the companies are making 250, and maybe we'll be able to reach in certain patients. There's other form of atherectomy that we don't have available right now, but in the future we may. So if I have an instant restenosis, I don't go with radial to peripheral because I want to have some kind of, for example, laser atherectomy. So I can do radial pedal or common femoral. Cover stents, there's a limitation to them. The company who make cover stent are making it smaller and able to go through 6 French. Thrombectomy, there's few devices that can reach the iliac, but I think still if we have a thrombus, we choose to go femoral, and certain stent sizes. So the main talk for this session is, challenging cases, aorta venous. So this is a case we did. It's a bilateral common iliac occlusion, and we did the whole case via one radial access. So why would I choose a radial for iliac disease? Is better imaging from above. It's easier crossability. I'm still able to do a calcium modification with the lithotripsy. And the stent deliverability, but you have limitation of what you can deliver through 6 French. So the largest stent you can do is 9x26 balloon expanded, but self-expanding for the external iliac and the distal part of the common iliac, you can deliver up to 8. But if you have someone with a large iliac arteries, I would still go groin. So this is actually our paper that we just submitted to TCT. We don't know if we're going to get accepted or not, but this is our 50 patients or so comparing to radial access versus femoral access of iliac disease. That's only iliac disease. And what we noticed, there's the rate of procedure success, there's no difference between them. The length of stay is much shorter with the radial access. The time of procedure is the same. And all-cause mortality, there is a trend toward less mortality with radial access, but was not clinically significant, statistically significant. So what we learned from this, we're really in the early age of radial to peripheral. I think we're maybe, where we were 15 years ago when we did a radial to coronary. The iliac, the femoral popliteal intervention is very doable. This is our preference right now for any iliac or femoral popliteal, unless there's this old stent there. And radial to peripheral actually can provide you a complementary access for pedal access. So you can put your catheter there, take images, then you do all your procedure through pedal. And thank you.
Thank you, Sameh. You know, we will discuss during the panel some of the bailout options for R2P interventions, especially for iliacs. I think it's a worthy topic. And without further ado, Dr. Chris Metzger needs no introduction, both in the US and outside. And there are a host of reasons why, but we'll limit today's discussion to just peripheral intervention. And there's no better person to talk about aortoiliac re-entry. I'm sure he's going to show some great cases. Chris, the floor is yours.
I wish my mom was here to hear that introduction. Thanks, Subhash and Mehdi. Let me ask you something. I didn't get the memo, so don't start my timer. Wait 1 second, please. I want to ask our esteemed moderators here. I didn't get the memo about this being case. So I've got about 5 cases. They're good teaching points. But if you want it to be interactive, we can call an audible. I'll go through a couple of teaching points and take them one case at a time and do it interactive. Which would you prefer? Interactive. All right. I'm from Tennessee currently, so I'm going to call an audible. Omaha. This is completely not what I was going to do, but let's make it fun here. All right. So honored to be here. Aortoiliac. I'm just go. If the slides, if you start the clicker here. There we go. All right. Disclosures. I just want to give a couple background, and then we're going to skip to a couple of the good cases, and we'll just make them interactive and fun. All right. Look, if we're saying reentry, it means it's a CTO or sub in the aortoiliac. That's a dangerous, potential, high-risk case. You shouldn't be doing them early in your experience, in my opinion. And you ought to only do it if you know the bailout options and all the other. And I wouldn't do them RTP, by the way, but that's me. I'm old. And I think you need to pre-plan these carefully with CT angiography, considering all the options, all the bailout options, and prepare everybody, the patient, the family, and everybody in your room, including yourself and your staff, for a long case. All right. I will always have 2 access, usually, often 3. Access to good leg first, take pictures, reassess, okay, and then use that to get a good second access with a roadmap and an ultrasound. I don't want to extend that CTO into the aorta or down by the iliac bifurcation, period. I don't enter the lateral wall. I get it. We can all hit it. It's a big target. It's not physiologic, and it's not safe. Work harder to stay in the lumen, okay? And then we could use nubs to get a pioneer in there. We may skip that. We'll see, but maybe I'll show you one quick case of that. You got to know your bailout options, and you got to carefully look at this. You ought to have, what we do is we pre-dilate conservatively, reassess, and then use a lot of IVUS and a lot of IVL if it's calcified. Have all the stuff that you need in there, covered stent grafts, occlusion balloons, Shorty 40 AF, X2, and a good relationship with your vascular surgeons. I've got 6 in my group. We get along very, very well. And again, I'll just say that if it's an 014 calcified microchannel, that's where an 014 wire will cross very nicely. It's the only time I use it. Otherwise, you use pretty much straight glide wires and an angled catheter. We try to stay within the lumen. If I can't do it from above, we'll go from below, okay? And vice versa. And then if there's a little nub and you can't get in across, then that's when the pioneer, use your ultrasound, hit the nub, stay in the lumen, keep going. All right. I'm going to skip this. This is microchannel, blah, 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 microchannel, IVL. I'm going to skip this on purpose so we can get interactive. All right, this is one we did as a live case for Viva last year. So a lady was incredibly limited by claudication, high-risk patient. She had a subtotal occlusion of her aorta, and it was heavily calcified. Because I was zipping through these, I don't have the CT angiograms. Trust me, we showed them at the live case. But you can see kind of occlusion over here, and you can see on the other side, you can see just below the left renal artery that heavy, eccentric, calcified lesion, okay? So let me just stop. Should we even do this? And I'll let you guys lead the interaction, and then we'll just zip through this and get to the next one if we can.
Dr. Eidt, what are your thoughts, in regards to this lesion and how you would want to approach this?
So you got it. How old is she? 45 or something?
No. She's old.
Oh.
And believe me, we had a couple surgeons on the panel, folks that I know very well at Viva, and our own vascular surgeon looked at all of this was not a good surgical candidate at all.
Everybody's a good surgical candidate as long as...
Even the brave ones near us,
Yeah.
they all say it with a microphone in their hand.
Sure, everybody's brave.
Yep.
I think I would put a covered stent on this and pray and assume I'm not going to, rupture it. But I think this is... In this era, this is an endo case. I would not do this open.
Okay.
I guess let me ask Dr. Eidt, if you don't, since we're making it interactive, can you walk us through surgically, or Ben, both of you can comment. We have 2 vascular surgeons here. To do this case, you have to clamp. Can you talk about the clamping and the renal arteries vicinity to the lesion, and how you would approach this surgically if you were going to do it, briefly, if you don't mind.
Well, so aortoiliac endarterectomy is still a reasonable surgical treatment for severe aortoiliac disease, confined to the aorta and the common iliacs. It doesn't work very well if the disease extends into the external iliacs. It's particularly appropriate for the 45-year-old woman that's got a kind of a distal aortic stenosis, almost kind of hypoplastic aorta, common iliac disease. Kissing stents in that setting where you have maybe a 12-millimeter aorta and 6-millimeter common iliacs, you wind up with a lot of material. I could show you several pictures of kissing stents that, personally, I prefer to call them effing stents in this location, that there really is a lot of metal that gets wound up at the aortic bifurcation. It really looks like a massive, almost like a bird's nest filter. You got a lot of metal in a small area, and they don't seem to work very well. So to me, one of the big features is if you're confined to the aorta itself and you can get above 10 to 12 millimeters with your stent, I think that's important. Common iliacs, if you can't get to an 8 millimeter in the common iliac, then I think you probably need to figure out a different solution, because my experience with it is just haven't had very good long-term results with that.
I'll just add one thing. Depending on, it sounds like this is a frail, sick person. Depending on, how bad their symptoms are, try not to do anything, obviously, but you had to do something. If I was going to approach this frail person surgically, I would do an axe bifem bypass, and that is, pretty well tolerated even in very frail people. But this, obviously, if you can get away with it with a couple pokes, it's probably better.
Good calls all the way. Just for time, I'll move on here a little bit. I've got a surgeon, one of our groups was trained down here in Texas with Carlos Timuron. He looked at the case with me, as did the world, as we were watching Viva with vascular surgeons. So here's the microchannel 014 from both sides. We've got triple axis. And if you'll notice here, a couple things. Once we cross, we've got a marker catheter so we can see how long the lesion is. And by the way, what's the distance between the renal artery and the IMA, okay? We heavily use IVUS anytime we're doing this. And then what we did is we put a Rosen wire in the left renal artery, okay? And the idea there is we're set for bailout. If the O-poop happens, we were going to put a tube graft in there, and we would put a VisiPro in there and laser fin like we would do for fenestrated grafts. So we had all that, the tube graft, everything measured, everything there, surgeons with me on this. So you got a Rosen wire from the left renal artery. Now we have big shock waves, 8, 10, 12, and shorter balloons. We didn't at this time. This was an 8x60 shock wave. And you can see we got a nice luminal improvement, and the IVL lets you do this kind of work without rupturing or cracking the aorta or embolizing, which is important. So we wanted to get a little bigger lumen, so we didn't, now I'd use a 10 or a 12, but we didn't have that. So back then this is kissing shock wave, so you offset the emitters here, okay? And then now you see a nice luminal expansion. And then, as mentioned earlier, we're going to put a covered stent graft here, so we've still got the wire protection here. We very carefully position between the IMA and the renal artery, again, guided by the ultrasound, guided by everything else. Put that in there, and then did post-dilatation. And nice final safe result. And there's a lot that goes into that. Okay, it's just a stent, right? Well, there's a lot of preparation for it, the IVUS. What is your bailout? What are you going to do if things go poorly, and so on?
Can I ask you, why were you concerned about the IMA? You made the point twice that you really want to identify it. Assuming you're trying to...
as you know, when we do EVARs, we sacrifice them all the time. A lot of the time, so if you don't have to sacrifice it, I don't think you should sacrifice it. I don't remember, quite honestly, because this was a multi-thon rather than the case presentation, whether there was a good reason for that. The next case, there was, but I don't have that. Let me just stop. One more case. All right, one more real quick. This is a pretty dang cool case done 3 weeks ago. This guy literally could not walk 10 steps. He's only 56, but this is an old 56. The same surgeon from Texas, we got a bunch, but just happened he sent him to me. He was sent for endarterectomy, no way. And we tried everything to do, like you said, let's do a lot of nothing, okay? Here's his aorta. That thing is just flat out nasty. And that nastiness goes above the renal arteries as well, okay? And so, again, access microchannels like this. We cross it with the angle, the 014 wires. And here's your IVUS. I mean, this is just really, really, really bad stuff. Again, eyes wide open. I promise there was a lot of discussion, a lot of ink on the chart, a lot of discussions amongst colleagues. So here, now we have the 12 by 30 IVL, which is beautiful if it's a bigger aorta, okay? And so you can see this. Notice that we're getting a bigger luminal gain up top. Same 12 by 30 in the distal aorta. Notice that the renal artery is getting worse on the left, okay? And again, we are going to do a little more work. We wanted to be prepared. So we did put a VisiPro stent in. It's not what I use for usual renals, but if we're going to maybe fenestrate it, that's what we do. You keep it out of the aorta so that you can put a stent in if you need to, okay? And then we got this after more shockwave. Now I'll just stop and we can finish here. Let me ask, to anybody in the room, all right, I've got this. We now have triphasic signals and no pressure gradient, okay? Who would stent it and what kind of stent? Actually phoned some friends. Sean Lydon, good friend. Joe Lombardi, good friend. FaceTimed, you know, the old guys doing FaceTime's kind of funny. And asked them, anybody say want a stent?
I was saying, why stent? Why stent this?
No, that's the question. And
yeah, I mean, we could leave. I personally would not.
Yeah.
Large fistula.
No,
I don't think so.
just the kidneys.
There's a little one, but I don't think there's a. You're sitting over here.
Being a case.
Yeah.
It's just the,
Oh, so we do have that. You're correct, filling up on the right side there. You know, and again, is that enough to do something different? And I have to go back. You know, quite honestly, sometimes it's great when somebody is in the audience. You'd think, Chris, what the hell? You didn't see the fistula? I honestly didn't see the fistula. So I was concentrating on a lot of other things. And I've seen the guy back in 3 months, so whatever the fistula is and hasn't hurt him.
what did this look like on IVUS now?
So the IVUS, so this is a good question because it looks pretty good here. I did IVUS it again. I'm going to lie through my, oh, it looked beautiful. There was no residual stenosis. I'm lying. There was still residual stenosis. Yeah. There were microcavitation, there was no dissection, and there was still every bit of a 30 or 40% narrowing. But there was no pressure gradient. I can tell you honestly, everybody said, oh, when I saw him in follow-up, he was great. He really was doing great in follow-up. It's only 3 months. So even if we're going to stent it, it's not going to be stented now, you know, and I think that's the point.
So, I mean, you brought a good point, is for us, for in general, when we have an iliac or distal aortic, we stent majority of the time because stent data looks great. The question is, not related to this case, is do we really need to stent now with the shockwave, the 8, 9, 10, 12 we're having, and the amazing result we're getting with that dissection, with that disembolization, and with the residual maybe 20, 30%. So that's the question that we need to ask ourselves.
I think it's a great question, and I think with covered stent grafts, you cover a lot of evils, but towards your point, if you're going to do twisted up, do you really need to do that? You know, so I think those are good points, and I should stop for sake of time. Sorry.
Okay, great discussion, and thank you so much, Dr. Metzger. We're going to move on to the next presentation. A lot of things to discuss, but we hopefully have time to get there. The next presentation is ultra-low contrast PVI, and we know that contrast is our enemy. And this is going to be given by Dr. Anand Prasad from UT San Antonio. Thank you, Anand.
So hopefully contrast is not the enemy. We'll see that. But what's common in all the cases you're going to see here for the next few days, it's contrast dye. So learning how to manage contrast is important. Here are the disclosures. And a lot of what I'm going to talk about, we've actually published last year in JSCI. It's a joint recommendations from SCAI and the National Kidney Foundation. So we cover peripheral vascular interventions, and I suggest you guys take a look at it. So what do we mean by ultra-low contrast? There's actually 3 categories of contrast dye that we can give. So one is low contrast, where the total amount you give is 1 time their eGFR. Ultra-low contrast is you're using the total amount less than their eGFR. And then something I really don't believe in is no contrast, PCI or PVI. That's where obviously we try not to give any. So contrast dye is used quite a bit. There's a lot of variation. These are data from Dr. Banerjee's XLPD study, where on average about 160 mLs of contrast is given for lower extremity cases. And I want you guys to get into the mode of not thinking about total contrast dye, but put it in a framework of their total renal function. So what's their renal function by eGFR? And understanding that when that ratio is approaching 3 or more, that's when you're at risk for AKI events, and that's when outcomes are worse. And that's true for coronary as well as peripheral. So how can we limit contrast dose? And I'm gonna go over lots of tips here, and we're gonna look at a few cases. So some of the basic things, and this is really a good talk for fellows, is just down to the basics. Use smaller sheets. You can even use 4 French now. There have self-expanding stents out of 4 French, but I often use 5 French sheets and long sheets for my below-the-knee work. Smart mask, we'll go over a lot of smart mask cases. Adjunctive IVUS, and there's some OCT crossing devices. CO2 imaging, and then staging, so we don't give a ton of contrast for a single case. Here's some of my personal tips. I don't do bolus chase angiography. I do selective angiography. I obviously use very selective catheters. I dilute my contrast. You get great DSA images with 50-50. You don't need to use pure contrast. I often do that with a power injector. You can now use diluted contrast with assist injectors. So you just load it ahead of time, and then you can control the amount you give. And then I use isoosmolar contrast. Part of that is we have data suggesting better limb and renal outcomes with isoosmolar contrast. So low osmolar contrast actually can hurt patients. You guys have all seen this when the techs hang the wrong bottle and the patients are in pain. And there's randomized controlled data out there that demonstrate more pain with low osmolar contrast than isoosmolar contrast. The other reason to think about contrast is recently, many of y'all, how many here had shortages of contrast in the last year? So it was a big deal, right? We were borrowing contrast. We really ran out of Visipake, and that really hurt our peripheral cases. And we published this in Cath Lab Digest. Actually, my fellow who was the lead author is back there. And we did a survey of interventional cardiologists around the country and how they were managing the problem with the contrast availability. And you can see, here's what people did. They used more CO2, they staged cases, reduced the amount of contrast, and they diluted contrast. So they did sort of the natural things you would think about doing if you didn't have a lot of contrast dye. Now, CO2 became of interest again when we had this shortage. And do people here do CO2 contrast? A few people, right? It's not as common as we would think. And obviously you get this inverted image. There's actually a society of CO2 angiography. We looked at CO2, and there are limited data to suggest that AKI reduction can occur with CO2 use. Often you end up using some adjunctive CO2. Those of you who are not familiar with it, you get this sort of negative image when you inject. And I would argue, if you want to say that iliac system there looks okay or patent, fine, but it's certainly not as detailed as you would with an iodine-based contrast. Here's a case we did when we had our shortage of contrast. It's a relatively straightforward focal SFA lesion, balloon and DCB, and you can see the image that you get. So we did turn to CO2 for a couple of cases during the height of our shortage in our hospital. So let's also look at our modern X-ray systems. I think all of us who have done peripheral work have used Roadmap for years. We have the Philips Azurion system, but almost any modern X-ray system will give you a Roadmap feature, and you can do a Roadmap image with very diluted contrast. And most systems, you can bring the bone in or bone out. You can bring your wire and catheter in and out, so you can digitally manipulate the image, and you don't have to keep puffing or taking multiple images. Just an example of how you do that, and particularly for carotids, it's very helpful where I don't want to keep puffing, but any type of peripheral intervention. Here we have a tight subclavian. We wire with the roadmap. We balloon with the roadmap. I position my stent with the roadmap. And then I use a small amount of contrast for a final image. So, you know, this is obvious to us, but many of the fellows are not familiar with road mapping. Here's another, we were talking about iliac CTO, single kidney iliac CTO, and, you know, just roadmap crossing and IVUS sizing and final picture. Simple tools are the best too. Don't forget to use your glow tape, your radio-opaque marker that tells you where to start, stop when you're doing atherectomy or landing a stent. And then, you know, what's always kind of annoying to the staff is when you draw all over the screen, but make sure you don't use some kind of permanent marker, but you can draw out your vessel and the lesion, and you don't have to keep injecting to take pictures. So some take-home points, be aware of contrast use in CKD. But, you know, every week people come to me and they're like, well, I don't think we should do this because the creatinine is 2. Do not avoid procedures in patients where they might benefit because you're worried about renal function. Just plan it out, be judicious in your contrast use, and use all your tools and technology to figure out how to do this. And the last thing is obvious, no-brainer, right? Avoid complications. I think many of the AKI events that occur in peripheral and coronary and structural cases are not because of the dye, because they bleed, or you have embolization and you're in there another 2 hours chasing your tail. So avoid complications in these CKD patients as best as you can. Thank you.
Thank you, Anand. That's wonderful. Dr. Eidt, please go ahead.
I've got a quick question for you. It looked like that subclavian thing was in a person on dialysis. It looked like the subclavian vein filled like right away.
That's right.
I assume there was access in that arm. Do you try to limit your contrast dose in somebody on dialysis?
On peritoneal dialysis, yes. When they have residual renal function, we do want to preserve residual renal function. That patient had fistulas, but then was on PD. And PD patients in particular, that RRF, the residual renal function, is very important.
So, but the question I'm getting at is there a harm to somebody already on dialysis? Can you worsen their kidney function, meaning you lose, for instance, they make no urine, they become anuric as opposed to...
Yes, that is worse. Heart failure outcomes are worse, and overall mortality is actually lower if you have residual renal function. Particularly if you're going for a kidney transplant, you want to maintain that RRF as long as possible.
Fantastic.
Thank you.
Anand, great talk and great discussion. One quick question for the panel. I do want to come back to Chris's case where he showed a lot of bailout strategies planned in advance. So the radial to peripheral field is advancing very fast, very quickly, and new devices are coming into the market, and Sameh showed some great cases. I would address this directly to Peter and Jun. Jun, do you guys at your institutions do R2P interventions, and are the labs, and many others, appropriately stocked to do it in terms of both planning and also bailouts?
That's a great question. So R2P I use as adjunctive crossing, oftentimes for iliac CTOs. I agree, though, if your plan really is to stent, you need femoral access in the event of a bailout. And sometimes you actually plan for upfront cover stent. So it's important to understand that there are advantages to radial to peripheral, but there are also limitations. The size of the equipment at this point. And then we talked a little bit about reachability to below the knee, but I would argue that the more primary issue is that you're so far away from the CTOs that you're trying to treat that you can't actually cross any CTOs that are significant below the knee. You can potentially do some stenotic lesions, but I think we have to be realistic about how far we can push the technology.
Is there much difference in cost between a comparable case done from the radial artery versus femoral?
It depends on your institution, right? It depends on the cost, what R2P sheaths kind of come down to. In our system, they've been a little more expensive. Sometimes you can't use other technologies that might be more expensive, like was discussed with some of the atherectomy devices. For us, we use it similar, even having been in kind of R2P iliac trial to what Jun was describing. We're using it as a crossing modality. You know, we'll use it I think that first case that someone had a fem to fem, perfect example of a situation where you don't want to complicate maybe a prior surgical access and work from above, though I will say when you talk to patients about it too, I say this is like a 95% coronary radial operator. When people are sometimes coming in to get their leg fixed, they don't necessarily see that benefit of working through their own wrist. If you give them the choice, they sometimes just want you to go from the leg to fix their leg.
We are looking forward to your data coming in soon.
Yeah. Absolutely, and I think the financial benefit, I think we don't know yet. But if you look at same-day discharge, because less risk of bleeding, we have that data from coronary, radial versus femoral, and there's a significant, and Dr. Amin did multiple publication who showed a significant financial benefit for coronary intervention when you go radial versus femoral, because the radial to peripheral is still in infancy. We don't know. We don't have enough. I mean, I think in our institution we've done 280 radial to peripheral. I think that's pretty high comparing across the country.
I would challenge anything, though, because what you're doing is you're using a limited set of equipment because you're RTP, so that you're not using cover stents, you're not doing other things, and so that would confound any look at the financial benefit of RTP.
Absolutely. We still, as I said, the technology is not there yet, and I think till we have same technology in both pathways, there's nowhere you can compare them in apple-to-apple situation.
Whenever these discussions result in important publications, do consider the American Journal of Cardiology for submission. So with that, let me invite Dr. Eidt, my dear friend and a fantastic vascular surgeon who speaks the interventional lingo. That's how I describe him. I'm sure he's going to give us a great education on endoleaks and what should cardiologists know about it. Dr.
Who
Eidt?
does EVAR in this room? Okay, so everybody else can go get some coffee. This is pretty specific to people who are going to be treating complications from endovascular aneurysm repair, if we can get this working. You guys do have great lingo, I got to say. We were way behind. Let's see. I don't think that's me.
We got the wrong slides.
Am I doing your slides? Let's see. We can do that. Just to remind everybody, speaking of lingo, the worst word that was ever invented is endoleak. No patient wants to be told they've got an endoleak. Because when you tell somebody they've got an endoleak, they think there's a hole in something, and they're leaking inside. And I don't know, does anybody know who invented this? Gary, you probably know. I don't know who invented endoleak, but it was a horrible...
It was a surgeon.
It must have been a surgeon. It probably was a surgeon. I really don't know where the word came from, but it's
probably Frank Veith.
It probably was Frank, or something like that. But it's just a bad word because it doesn't leave people very comfortable. Those of you who are not familiar with this, probably the only time you'd ever see it would be on a board exam, the type 1, 2, 3, 4, and 5. All you really probably need to remember is that type 2 is typically a sort of a low pressure retrograde filling back into the aneurysm sac, either from lumbars or an IMA. That would be the most common. So we'll present an 80-year-old man. He's had an endoleak that's noticed 12 months after an uncomplicated EVAR for a 5.2 centimeter aneurysm. Now, your first question would be, why are we fixing a 5.2 centimeter aneurysm in an 80-year-old man? So what's the purpose of aneurysm repair? Is to prevent you from dying from an aneurysm. And at 80 years of age, a 5.2 centimeter aneurysm probably has about, what do you think the estimated annual risk of rupture of a 5.2 centimeter aneurysm is? It's about 1%. So he's 80 years old now. I don't know who fixed this aneurysm. It was probably me, for all I know. But we have to be cautious about eroding the indications for treatment because these small aneurysms have such low risk of rupture. And you also have to ask the question, and I don't mean this facetiously, ruptured aneurysm is not necessarily a bad outcome. If your choice of death is metastatic lung cancer versus a ruptured aneurysm, you really have to think twice about fixing an aneurysm in somebody who has other significant comorbidities and social situations that may be challenging. For instance, if you're an 85-year-old man with metastatic prostate cancer and your spouse of 57 years died last year and you're living in a trailer in Tyler with a three-legged dog and smoking a cigarette and having a cup of coffee is your high point of your day, you really have to ask yourself, do I really want to fix a small aneurysm in this man? It'd be criminal to do so. That's editorial. Anyway, so here's this CT scan, and you can see there's an endoleak there. That's probably coming from an IMA. Should we do anything about this? 5.2 centimeters, it's asymptomatic, 1-year follow-up, 80 years old. Who would fix that? So the question from Dr. Rosol is the key question, is the aorta enlarging? And the answer in this man is no. His aneurysm was 5.2 last year when it got fixed. It's 5.2 centimeters now, so it's not enlarging. It's a low pressure, probably retrograde endoleak, so you probably leave this alone. I'll skip through these since we got there. So since this is small and stable, it's low pressure, I'd observe him another 12 months and see how he does. So you got a second case, 75-year-old man, he has an endoleak, he's 18 months out. He's got a few other things. I don't even know what a maze procedure is. What's a maze procedure? I'm sure you all do this.
Not that kind of maze.
What is it? No eye? Okay. That's what was in the chart. I just copied it out of the chart. I cloned and pasted straight out of Epic. It's the beauty of Epic. So here's some CTs. I'm going to show you just some selected pictures. This, I think, is pre-op. He's got a kind of a little bit of a FLA, the funny-looking aneurysm. It's not a real typical fusiform aneurysm. So pre-op, he gets done, and you can see I just put that arrow on this kind of a bulge, kind of an ulceration, where it's not a real typical fusiform aneurysm. See, it's a little funny shaped. Most aneurysms are a little more uniform in size. Anyway, he gets an endograft, and we're pretty happy with the result. This is 1 month post-op. We noticed two things. One, he's got a big infarct in the upper part of the kidney. And two, there's pretty clear contrast that's outside the endograft. We wait 18 months, and in fact, he's increased in diameter from 6.2 to 7.2, and he's got an endoleak. So this is a guy we feel we probably should treat because he is enlarging. And the other thing I would point out, it's very difficult to know for sure what the kind of endoleak you have is. Sometimes our radiology colleagues say, oh, this is a blank and blank. There's a guy down at Methodist in Houston. He's one of the Siemens guys, but he really pushes the 4D CTA, the time-resolved CTA, for really helping to define the nature of the endoleak, where you can see CT over time instead of just as a snapshot. And I think it does help sometimes to differentiate, the nature of the aneurysm, whether the leak, whether it's a type 1 or type 2. So in this case, basically what we've used one of these tour guides, a steerable guide sheath, and put it in the right hypogastric artery. I think you might be able to see. Is there a laser on this thing? I wonder what that does. No. But you can see this injection, and that's filling in kind of this lumbar branch, and you can see it goes right back to the aneurysm. And here, that's the tip. What we've put, that's a 6 French sheath that's in the internal iliac. Then you got a 5 French glide cath. That's the steerable tour guide. Here's a microcatheter, is I think 2.3 French. And then I think this is a choice PT wire that's brought back to the aneurysm. And then with this, you can sort of see, once you get your microcatheter, you're in the aneurysm itself. And so my goal typically is to try to anchor the coils in the aneurysm and then work back into the peripheral artery. So here you can see this happens to be a penumbra. Any of the variety of companies, you can see how this kind of slides in. You really can't hurt anything. You're inside an aneurysm. I'll just show you some quick pieces of this. I'm not sure you can embolize too much. I've never had anybody get sort of like paraspinal claudication or some kind of muscle pain from these coils, but it does make you wonder sometimes after you throw a lot of this metal in. And here we've pretty much eliminated that one, and things were going so well, I will almost never do both sides at the same time. But the tour guide, that's that steerable guide sheath, it really does make a difference in terms of your access for visceral arteries. So I use it pretty liberally. So we went over to the left side, did the same thing. You can see we're sliding these little worm-like things up. And then we went up to the SMA. This is a little trickier to follow. Those of you who are familiar with the meandering mesenteric artery, this is a little later shot of that. You can see it kind of winding up in the left upper quadrant and eventually filling down into the IMA. This is kind of an overlay of where that artery is going. And it comes back around, and then here's kind of more or less a final shot where we've embolized the IMA and 2 lumbars. And this is kind of the typical pattern of filling of these lumbars. There's often, almost always, an inflow and an outflow vessel that maintains patency. So in general, just for board exam type stuff, I would fix all type 1s, 3s, where you have disjunction of the device itself. 4, we virtually never see anymore. That was where you sort of bleed through the fabric. And type 5 would be an enlarging aneurysm in which you can't demonstrate contrast. So pretty much fix all of those. And then type 2s, if they persist for a long period of time, we'll sometimes fix them. But generally, if the aneurysm's not enlarging, we would not fix a type 2. That's all I had to say. Thank you. Yeah.
John, one quick question.
Yeah.
Is your wife the penumbra rep?
No.
Okay, that's all I had. I'm sorry.
No, I have no conflicts of interest.
I have a question for you, John. So let's say you see someone with maybe they had a 5-centimeter aneurysm fixed, which we see, every now and then. And then now are you going to wait on an endoleak to make that aneurysm get above, to 5.5 or greater before you treat it? Or are you going to, say any growth, even if it's below 5.5?
Oh, I see. So you fixed a 4, and it's gone up to 5,
right.
And you still haven't even hit the threshold for fixing
the risk
it at
of rupture
5.5.
is still, below the threshold to fix it.
Yeah, I mean, I think once you've bought into fixing it, I think if you've got an enlarging aneurysm, even if it's small. But I do think the point, though, that the risk of rupture of these small aneurysms is pretty low. And if you start getting up to a 7.5 and 8-centimeter aneurysm, your room for error is lower because the risk of native history of rupture is higher. So my willingness to watch a large aneurysm, even if there's really not a lot of change in size, I might intervene for even a very small change in size, where a smaller aneurysm might be a little more conservative.
John, one last question, because I think this is an important, scary answer over here. Beyond the size, do you take anatomy into consideration as far as how long is that infrarenal neck? What's the landing zones look like to shade you off of the absolute size consideration?
Yeah, Gary, I think that's a really important point. If I had an aneurysm myself, and I've got good anatomy, meaning a long neck, and I don't have a bunch of calcium, or I don't have a bunch of thrombus, and I've got good iliac arteries, you can expect very good long-term results from EVAR within the, quote, IFU. When you start, quote, pushing the limits, right, and you start doing things with real short necks, angulated necks, lots of calcium, thrombus, things that are going to compromise the seal of this graft, then you really do have to be more thoughtful about, there still is open surgery. They still do actually make knives, and you're welcome. You should come to the operating room sometime. It's a lot of fun. You get to see things you don't normally get to see. But persisting with endovascular approaches in some patients, I shake my head at times. If there's a philosophy, there was a study done in England years ago. They call it the EVAR2, where they basically took people who were too sick for open repair. Somebody said, "You're just too sick." Mostly it was a thumbnail. Too sick for open repair, so we're going to randomize you to either EVAR or go home with a 6-pack and a fishing pole. And basically, you follow those people over 5 years, and the survival curves are identical. There was no survival advantage for fixing aneurysms in sick old people, because they're still sick old people when you've finished the procedure. And I think the way I look at it is, if you have a juxtarenal aneurysm and you say, you're too sick to have a clamp placed above your renal arteries and your aorta fixed definitively, then maybe you just don't need anything done, that your survival is just not that long, especially to justify doing some super complex perivisceral stented fenestrated graft that really isn't going to buy you any long-term benefit. So I think the global picture really does matter a lot, Gary.
All right, I apologize for the sake of time.
I totally agree with you. And the thing is, your young colleagues, the Society for Chimney Snorkels and bizarre outcomes is way ahead of you, that they don't want to take these people to open anymore. I totally agree with you.
Yeah.
You've got to, you know, there's a good surgical option for these patients with terrible anatomy, and if they're not good surgical candidates, your first choice is maybe you should go fishing.
Yeah, it's really true.
I think
Real
the
quick,
lesson,
remind us
I'm
how
sorry, for the
frequently
sake
these
of
happen.
time, I'm going to have to do timeout. That's why they have us up here as moderators. For the sake of time, we're going to have to move on. But I think the one lesson from this, as we get, you know, as you get some gray hair, is that sometimes less is more. Less is more, and we don't always have to do something. So Dr. Ben Colvard from University Hospital's Harrington Heart and Vascular Institute, ascending aortic pseudoaneurysm. Thank you.
Thanks, Mehdi. And thanks for the invitation again to speak this year. Who in this room treats ascending aortic pseudoaneurysms? Okay, everyone else can go have a coffee. No, so this is actually a case from a colleague of mine that I was asked to present here, Dr. Baeza, cardiac surgeon, and Dr. Jun, one of my partners. This is a patient, let's see, large green button. Press it harder. There we go. Disclosures. So this is a quite complicated patient. A 61-year-old gentleman. He had a history of drug use. He had at least three operations that I could find in the chest. Cabbage and tissue AVR. He then developed endocarditis from this. He had a big operation in 2022 with debridement of this aortic root abscess, a big reconstruction in his outflow of the left heart, and then presented again a year later with recurrence of this endocarditis, had a redo AVR with debridement of an abscess, and he was growing candida at this time. So this is a person who's had 3 open heart surgeries. He's, at this point, fairly debilitated, frail person. Was living in a SNF, recovering from his last operation in January, and was brought to the ER for just, you know, malaise, weakness, just not looking well. Had already completed a course for his fungal infection. Basically, what was found was a large mass compressing the RV inflow tract, and a large ascending aorta intramural hematoma, and an almost 12-centimeter pseudoaneurysm of the ascending aorta near the suture line. So you can see here some images of that. You can, if you look closely on the, let's see, is there a laser here? No? On the image on the right, you can see the jet of contrast coming out of the ascending aorta, filling that pseudoaneurysm, and this is presumably, you know, breakdown of his repair from his ongoing infection, despite completing his course of antifungals. So the neck of that pseudoaneurysm was about 4 millimeters wide, and at this point, you kind of have to think about, you know, what the heck are you going to do here? Because you almost wish he just had a zipper for his chest, because it's been opened so many times, and you know it's going to have to get opened again, even after this potentially. This patient actually had consultation with palliative care, and we proceeded with so the challenge is a large pseudoaneurysm, patient with multiple prior reduced sternotomies. Actually getting into the chest with this large pseudoaneurysm is dangerous in and of itself, because you can easily get into the pseudoaneurysm without control. The thought was to basically, he was only an endovascular candidate at this point, versus palliative care. And actually any operation for this procedure might be considered palliative, regardless of what you choose to do. So they chose to do use an ASD closure device to place across the neck of the pseudoaneurysm, just to seal that off and depressurize it. This is the Amplatzer ASD closure device that was used. If you look at B, the waist length 3 millimeters, so actually it was going to need to be, you know, it was not certain that it was going to fit across it, but I don't think there was really a better option here. And this is, you know, in the world of ascending aortic endovascular interventions, you can probably argue to do anything you want because there's no data, okay? There's no devices that are approved for use in this area. You kind of have to use your own judgment and creativity to come up with something that's going to hopefully work. So this is an access from femoral. You can see the jet off the ascending aorta. Large pseudoaneurysm was actually pretty easy to access with a catheter. The procedure itself was pretty uncomplicated, pretty quick to place that Amplatzer device. And follow-up, you can see that there's no further filling on the immediate next day post-op CTA. The patient actually did pretty well in the ICU and subsequently was discharged, and he's been seen 3 months, in 3 months follow-up with some shrinkage of that aneurysm sac and actually symptomatically feeling well and doing okay despite being, you know, still recovering from all of his major cardiac operations, but still alive. So he has had negative blood cultures. I think the key here is that these are cases that you don't necessarily want to tackle on your own. You need to load the boat on these, get all of your cardiology, vascular surgery, cardiac surgery friends to help you with these. There's no IFU to guide you. There's no studies to guide you on here. You have to be creative and come up with something specific to to each of these ascending aortic problem patients. And not every procedure here is going to be necessarily definitive. Sometimes we're dealing with, you know, something to get someone out of Dodge or palliate someone. That's it. Thank you.
Thank you. I think sometimes the question arises, why are we talking about endoleaks and pseudoaneurysms in a cardiology or interventional cardiology conference? I think the overlap between specialties is growing, and I think we are working together. I think good vascular centers have an ecosystem where surgeons and interventionalists collaborate and discuss these strategies and these procedures openly and in a candid fashion and plan out the entire procedure in advance. So I think to demonstrate this further, there cannot be a greater controversial topic, which is becoming less controversial, is endovascular common femoral artery approach. Now, there could be many ways to look at this question, but no better person than Dr. Jun Li from Case Western to address this. Jun?
Thank you, Subhash. Thank you. All right, these are my disclosures. In addition, I really hate amputations. So I'm going to make this one a little bit more interactive as well, taking after Chris Metzger. So 69-year-old guy, he comes in with rest pain of the right lower extremity. His background is that he has hypertension, dyslipidemia. He's had coronary disease, had prior stenting, peripheral artery disease, pretty significant history on the peripheral artery side. So he had a right lower extremity common femoral SFA IVL, complicated unfortunately by embolization to the profunda, was rescued. This was in April of 2022. Had recurrent common femoral disease and had an endarterectomy in June of 2022. And then progressively worsening pain actually over the course of the last year. Didn't really tell anyone, was eventually started on cilostazol by the surgical team, but unfortunately no help. And he comes back to clinic in January of 2023 saying, hey, I still have pain, and it's worsening. Now he's got dependent rhubarb, small little superficial wounds on the right side. And you can tell by his ABI, TBI on the right that basically everything is probably down again from the common femoral endarterectomy. And here, I'm not going to allow the whole CT scan to play, but you can see on the left side here, sorry, on the right side, the entire common femoral is out, and there's some reconstitution of the profunda, and the entire SFA is actually out as well with reconstitution in the popliteal artery. So here's the angiogram. So here's the clinical challenge. How are we going to address this? When I talked to him in clinic, I said, you need a redo. Let's get you to the surgeons again. And he hawed and hummed for 3 months about this. He said, ultimately, I don't want to do any more repeat surgery. What can you do? So I ended up taking him back to the cath lab. So then the question is, and I'll ask my panelists, how would you attack this? The occlusion starts essentially at the site of the endarterectomy. You would anticipate that it's probably rock hard. There's some reconstitution of the profunda. Profunda is also occluded. The SFA is occluded. And you have essentially a blind pouch, and then all the way into the reconstitution in the popliteal segment.
I ask, if you don't mind, Jun, because this is a great discussion here, and I'm going to ask Dr. Eidt, is it true that you have to go back surgically? I mean, I guess the question always for me is that, sometimes we do endo and it fails, and maybe we need to do surgery and not do another endo. In other situations, maybe we go surgical, and the surgical approach fails, for whatever reason. Maybe it was technical, maybe there is some other issue. So what is the need? Is it a gospel that, we have to go back surgery? What are your thoughts about a situation like this?
Well, one thing we need to know that the Achilles heel of vascular surgery is groin incisions. Groin incisions are complicated by some type of lymph leak / infection about 10-fold higher than any other peripheral incision that we make. And it presumably has to do with lymphatics and all this stuff that comes out of your toenails that winds up getting collected in your groin. It's a hard area to sterilize, but surgical incisions, especially redo surgical incisions in the groin, are really prone to infection. So this is a high-risk case from the surgical side. We don't want to do a redo procedure if we can avoid it in a groin and a frail guy and he's had a bunch of procedures. So I think you can make an argument that a percutaneous approach is optimal. The second point I would make is it's pretty good. We don't see exactly the whole thigh, but there's pretty good reentry collaterals in the popliteal. So the key vessel here is not the SFA, but it's the profunda. If you can get a pulse in a profunda, few people wind up losing their legs with a pulse in their profunda. We focus a lot on the SFA, but in many ways the SFA is almost a cosmetic vessel. God's bypass is through the profunda and into reentry collaterals, especially above the knee. And in some of these people with a good profunda, the pressure gradient from an upper thigh cuff to a lower thigh cuff will be negligible. So that doing treatment to the SFA isn't doing anything hemodynamically really to improve flow to the foot, which is what you're trying to do. So I think a percutaneous approach here makes sense and really focus on the profunda and cross your fingers.
Chris, I think Dr. Lee's question was that, what approach would you take in this situation? Would you go antegrade, retrograde, and how would you do it retrograde if you were going to do it?
So I think the last two, Ben's talk and the comments here in this case, represent the ideal situation for collaboration. We should be thinking together, unlike some of the articles that have been in press in the last week, which we need to get away from. We need to get back towards bringing that best. Your case was phenomenal, and it's everybody working together. The think of how do we do this? Some people wouldn't think of the profunda question because they didn't have your perspective. I know Jun would. So I'm with you. I would try to get across into the profunda, open that up, and do some definitive therapy. I would also talk to the surgeon first. And what I mean by that is, did you ligate the femoral or the SFA before I start going mucking around in there? I've had that a couple times, and even my hands won't get through a surgical stitch. So I would ask the surgeon, what was your technique? What did you see? What do I need to know from when you were in there? And so I think I would start by going across the other way. I would have the leg prep from below because you could always go retrograde if you needed to. But whatever I do, I would preserve the access to that profunda. And you can always, let's say you did that and did a DCB after you did whatever you did, you could always come back later if you needed to fix the SFA, if you didn't have to go retrograde to fix it.
Great. So taking that approach. I went from the top, I went from the profunda, actually. So this is a proximal profunda retrograde stick. A lot of wires were utilized, sacrificed in this case. Could not penetrate. So I said, what the heck? Let's try the Pierce technique from the Japanese. Didn't work. And I said, let's try step by step. Didn't work. I get into a, it looks like a venous connection here, actually. So I think with the step-by-step, I went to venous side.
Step-by-step, meaning with laser?
With laser, yes, step-by-step with laser. For 10 seconds? Yeah. So step-by-step is essentially you have a laser up front to soften the rock that we're trying to break through. So softening it will allow you to penetrate the CTO cap from whichever direction you're trying. ultimately, when at the end of like 4 hours, I said, the SFA is really rock hard. What I can do is stick the calcium. Similar to how we stick the SFA stents, right? You can use the calcium as a landmark. So I stuck the calcium. We went oblique on our II, and I pulled the needle back, and I eventually was able to wire. You can see it's wiring into a subintimal space, but it does get looped into a sub-I space. I was fortunately able to get it into the common femoral and into the external iliac stent, confirming that I was true lumen. I reversed the system, took a picture in the popliteal to confirm that we were good distally and to look at the runoff before we start. Some balloon angioplasty was performed, and here this is an IVUS of the common femoral site. And as I was curious to see what was really the constitution here, and you can see there's a little bit of subintimal space where we had entered. And then within the common femoral site itself, there's actually a lot of thrombus. So aside from that rock-hard scar tissue, there is also a pretty tremendous thrombotic burden. I actually did balloon angioplasty, drug-coated balloon. I was actually quite satisfied with the outcome here, so I left him alone. I said, I'm not going to stent it. I'm not going to burn any bridges for the profunda in case something happens to the patient. Lo and behold, he comes back a couple weeks later. Hey, my leg still hurts. So we took him back, same picture. This time, I was able to cross relatively easily from antegrade. I spent more time trying to get through that profunda to really have that backup system in the event something does go down. I even tried something called ECART, which is electrocautery, with a stiff wire, trying to poke into the common femoral, and I just couldn't, even using a balloon on the other side to make a hard surface for me to push against. Ultimately, I did end up placing a supera as well as overlapping alluvia into the SFA. He's actually doing well. This is actually a couple of months afterwards, so he's still doing quite well, fortunately. His ABI, TBI, you can see there's improvement in the waveforms. The ABI the day right after was 0.7, but he does continue to do well, and his wounds are all healing. Second day's presentation, this will be a little faster. 64-year-old woman had a pseudoaneurysm. This is hot off the press. I just did this case right before flying here. So she has non-ischemic cardiomyopathy with an EF of 35%. She's hypertensive and has dyslipidemia, BMI of 44. And you'll see that actually comes into play in this case. She had a recent procedure on her right lower extremity from another facility, complicated by a large pseudoaneurysm on the LFA axis, and they had attempted thrombin injection. The patient was actually referred to Dr. Colvard for assistance, but you can see why this might be a poor surgical candidate. That tremendous pannus would get in the way of an open repair of this really large pseudoaneurysm. So as a limb salvage team, endovascular and vascular surgery were on the call together, trying to decide what is the best route to fix this pseudoaneurysm. And the decision was that endovascular was likely the most appropriate approach here. So I took the patient to the cath lab, brachial access obtained, and here you can see there is the pseudoaneurysm, but you can't really make out exactly where the neck is. So I went oblique, and here you can see really nicely the neck of the pseudoaneurysm. I did IVUS across this. It was about 6.9 millimeters. My first thought was, why don't we try thrombin injection? So I did a balloon occlusion across it, keeping the II at that orientation. I obtained micropuncture access into the pseudoaneurysm. I injected a little bit of contrast to confirm that I was really in the pseudoaneurysm before I started injecting some thrombin. And despite that, this was an 8 millimeter balloon. Despite that, when I let the balloon down, yes, there was reduction in the volume of the pseudoaneurysm, but it's still persistently flowing. So I did end up doing a cover stent that we had discussed with Dr. Colvard. So that lady did well, and the next day, her ultrasound actually showed a resolution of the pseudoaneurysm neck. So case one learning point, sometimes metal scaffold, unfortunately, is needed. Current assessments or procedural completion is really imperfect. Very high vigilance for vessel closure based on the patient's clinical presentation, and low threshold for non-invasive testing if there's residual concerns. Case two, facile management of pseudoaneurysms. Make friends with your vascular surgeons. You will need their help one way or another someday. Large neck pseudoaneurysms likely need repair, but in this specific case, prohibitive due to body habitus. And then tube view fluoroscopy may be helpful in identification of branches. Thank you. This is Bam.
Let me introduce Mehdi Shishehbor, who doesn't need any introduction. But for those who are not familiar with the abbreviation of DVA, it is direct deep vein arterialization, a procedure that I have not yet done successfully. So that's a claim, and I want to be open about it in the spirit of CVI, and I have a lot to learn, and nobody can do it better than Dr. Shishehbor, who has just published this landmark study in the New England Journal of Medicine. So Mehdi, you have a few minutes to share some key points.
I don't like this position because they're showing my head. I'm the bald spot, so I can't work from this location. That's not going to work for me, man, Chris. I'm sorry. So I'm coming here, man. The camera crew, we got to change this, or I'm coming with a hat next year. You're making me depressed. So we are running out of time. We have about 6 minutes, and I have a talk today, if you're interested in DVA, which is completely technical. No data, just technique. How do we do it? How do we select? At 1:53 p.m. this afternoon. So please come to that talk if you want to learn the technical part. But I felt it was important to understand the data first because it's a new technology, and before going to technique, let's understand how do we get to the point that we think that this may be a good idea for select patients. So this was, and this is my consulting stuff, you can see it on the website. Bottom line is that this was the summary of the data. The summary of the data. We showed in Promise 2 that this obviously was a landmark study of no option patients. Let's be very clear. These are patients that are not candidate for endovascular, all the fancy stuff you've seen this morning, and or surgical bypass, either because they don't have a target to bypass to, or because they don't have a saphenous vein graft to get there. So these are no option patients. The patients were very sick. They're all Rutherford 5 and 6. We did not do this in rest pain. I see these things on Twitter. Is crazy. We didn't do this in rest pain. We didn't do this in claudication. Every patient in this study had Rutherford 5 and 6. And yes, we had very sick patients. It was during COVID, and we did allow end-stage renal disease to be a part of this. I'm going to skip this. I think you all know about CLTI, and that's a disease that is common. The procedure requires 3 pieces of equipment. 3 pieces of equipment. The rest is all technique and how we do it. The first part is this arc or a reentry device, because remember, you're going from the artery into the vein to make the vein become an artery, reverse the flow, and get the blood flow down to the foot. Well, the veins have the valves, and that was one of the limitations of the early surgical data, which we used to do 100 years ago with this DVA that we used to create, is that we didn't destroy those valves. And this vector deals with those valves in the veins and destroys the valve. The third part is the stent grafts, and that has to do with the fact that there are a lot of tributaries, and if you don't eliminate those tributaries, you get proximal steal, and the blood will never get to the distal foot. Remember, you want to take the blood from the proximal calf and divert it all the way to the distal foot. So if you have a lot of tributaries and veins, they're all going to steal the blood proximally, and the blood will never get distally to the toes. That's it, these 3 equipment. So this was a multi-center study. There were 105 patients in the study in 20 sites, and these were the inclusion exclusions. Basically, very few exclusions except the life expectancy and severe heart failure. End-stage renal disease, diabetes, all the other stuff, gangrene, required a TMA, everything was included in the study. And the primary endpoint was to beat the performance goal of 54%, which was, by the way, the 95% cut point for published literature. Now, we all know that the published literature for no-option patients is very limited, very limited. But despite that, the FDA made us use the 95% cut point, meaning that the mean of the survival for no-option patients in literature is about 44. This was the 95% cut point of the outcome in the literature. And then secondary endpoints. These were all the sites, and as I said, again, we included dialysis patient Rutherford 6. These are the baseline characteristics. So about 69% were male, and this is something we are very proud of. When we do randomized clinical trials, we can't enroll patients from lower socioeconomic status, African Americans, Hispanics. In this trial, almost half of our patients were Hispanics and African Americans. And we are really proud of the fact that we are able to offer this kind of therapy in this population, because this is the population that presents end stage. They wait, and when they show up, they have this severe disease, and they end up being the no-option patients and end up with amputation. And the rest of it, you can see 20% of the patients had dialysis, and about one-third of the patients, more than one-third of the patients, had Rutherford 6. These are the kind of patients you never see in any study that we do in the endovascular field. This was the primary endpoint, so we beat the Bayesian analysis, but this is like kind of confusing. Well, what's the bottom line? This is the bottom line, in my opinion. In our center, when we say there is no option, it typically, if not always, it means amputation. I don't know how it is for the panel, and if we have a couple of minutes, we can discuss it. It's very rare that we say no option, because these are patients that are end stage, they are very advanced, they have large wounds, and there is no way with medical therapy, which means nothing basically, wound care, we can improve enough perfusion to heal them. So in this study, in no option patients, we had 66 patient amputation-free survival. That means either they were alive or they had their leg, whichever came first. The limb salvage rate was 76%, and the survival rate by itself was 87%. And those are the p-values for those that are interested. This is another way of looking at it again, and I'm going to skip that. This is kind of a subgroup analysis of looking at different populations, and you can see that this, I mean, this is a small study, right? 105 patients. It's not 20,000. We are cardiologists. We are used to big trials, 30,000, 40,000. This is 105. But still, you can see that the trend of the outcome is in favor of the TADV and the percutaneous DVA approach, except the dialysis patients. And this is the story about the dialysis. The bottom line is that the dialysis patients did benefit, but the mortality was so high. So the amputation-free survival was not great in the dialysis patients, because they never made it to 6 months for us to assess their leg. They died in the early days. So if you have CLTI and you have end-stage renal disease, you have a very bad prognosis. This is the wound care. I mean, at the end of the day, yes, we want to save the limb, but if the patients have wound, I mean, who really, like, did we do our job? I mean, we should always focus on wound healing and time to wound healing. Yes, we want to keep the leg, but you could have the leg, you still have your ulcer. We didn't really, we started this to heal the wound. And this is what we showed, is that, we're able to heal 30% of the wounds were healed by 6 months, or they were healing. So 76% were either healing or healed, 30% completely healed by 6 months. And this is another way of looking at the pain scale. A lot of these patients, obviously, they have not much of a perfusion. They have no flow in their foot. They have desert foot. They have a lot of distal foot pain. And you can see that the pain scale improved. And the Rutherford class, obviously, when we started, as I said, everybody was 5 and 6. 5 is a light gray, 6 is a dark gray. As we move forward to 6 months and 1 year, and some of these patients were followed up to 1 year, the majority of the patients actually became Rutherford 0, because we revascularized them and we were able to heal them, or they were healing their wounds at that time. So key learning points, and we get into the technical aspect of this afternoon if you're interested, all technical. TADV with lymph flow system is teachable and reproducible. The reason we say this is that of the 105 patients, we were successful in 104. So only one patient failed. There was significant knowledge that we learned around the venous anatomy, because I will show you this afternoon. We need to get lateral plantar vein access, and that's not something that we do. We are not used to doing that, and we just need to learn that. It's a small vein. You need to use the ultrasound. You need to become familiar, and so on and so forth, and we can discuss it this afternoon. Ultrasound is key. Without ultrasound, you cannot do this procedure. You have to be very comfortable with ultrasound, and you have to have good techs to support you, and consistent with patient follow-up. Listen, we all know if you treat CLTI, it's a chronic disease. This is not just, I did the procedure, goodbye, come back next year. You have to see these patients frequently. There is a lot of wound care. You have to partner with podiatrists, wound care experts, and you have to do it as a team. It goes back to what Subhash was saying. We are a multidisciplinary team. No single specialty can do this. It's impossible. It's too much. It's too much. We have to work together as all the specialties coming together, united, to try to save the patients and save their legs. And obviously, the pandemic helped us. So in summary, 76% limb salvage rate, 99% technical success. We can discuss patient selection and the technical aspect of this afternoon if you guys are interested. Thank you very much, Subhash.
Mehdi. Amazing. Very impressive. You know, I'm going to give a more traditional TED Talk. I've just edited my presentation to have 3 slides. So what I'm going to do in the interest of time, and that lunch is already served, is to show just the clinical challenge. And the backdrop of my talk is that everyone actually does not have to do advanced endovascular interventions. Everyone does not. But I think our societies, both surgical and Society of Coronary Angiography and Intervention, SCI, is on a mission led by, in the upcoming programs, by Peter Monteleone and Jun Li, where some basic endovascular skills are known by coronary and structural operators. Because one thing is very important, that although other complications are dropping, access site complications are not. And it is directly proportional to the size of the vascular access. So there are some very fundamental concepts, and I'm not going to belabor the point, and I'm literally going to use about 3 minutes and then leave it for the discussions and conversations over lunch. So the 3 challenges are how to deal with calcified iliac arteries. We do it every day. Second, if we are doing a non-traditional vascular access, how do we plan with our surgeons, with our imagers, and where is the right place to stick, and can it be done? And then finally is that if you require some complicated common femoral and iliac intervention in your path to performing a large bore access for a coronary or structural case. And I want to remind you, this is not off the books. It is actually a guideline level recommendation, time A, and level 1 is that you could do that if you need to facilitate coronary and structural intervention. But there are various ways to deal with it. So let me just highlight one case that, you know, you are getting into a routine case. This could be any case. And I've cut out these images, so you are advancing your sheath or your dilator, and you see this bend in the dilator or in the sheath. And this is a good time to stop and think what to do. These cases have multiple different steps, but the sentinel step is to recognize this and either ask for help or to take some remedial actions of how to address this. And in this particular case, we actually did protected dilation. We did IVL first, implanted a covered stent, and then dilated within a covered stent with large caliber balloons to facilitate advancement of the sheath. So my first message is that when you are dealing with tortuous and calcified iliac arteries, imaging and pre-planning, either with your imaging colleague or with a surgeon, and if you see these kinds of dilators and sheath movements, I think this is a good point to take stock and plan the next steps carefully. The second case and the second concept is, can you actually place a covered stent in a common femoral artery and actually get access in it? Now, it's a highly controversial question. However, if it is well planned and the space between the covered stent's adherence to the vessel wall is minimized with good planning, appropriate therapies with calcium debulking and expansion, and again, these cases have 9 or 8 slides. I'm showing you one. This was a recently placed Viabond stent and a percutaneous access through a Viabond stent with pre-closure with perclose to dilate the stent and place a Impella catheter through it. Again, the key parts are, is the profunda flow is going to be compromised? And second, how do you plan to have antegrade access if you actually need to get this done either during the same procedure or at a later stage? So again, a clinical challenge for us to think about. I'm sure we're going to discuss this in interdisciplinary meetings around the room. The last part is axillary access. This is a case I did with Dr. Eidt. We planned the case thoroughly. You can imagine we are not doing this because we have easy common femoral access or radial access or other access. This is required because of certain contingencies in the patient's history, presentation, clinical exam that are outside the scope. But the key part of this picture is where to stick. And that is an important question. And it is not enough to know the 3 segments of the axillary artery and go into the axillary fossa and try to get vascular access. This needs to be carefully planned with CT imaging. I can also tell you that ultrasound live guidance is important, not just to avoid some amounts of calcification, but you can also avoid some parts of the nerve plexus if you do it. And how the patient is going to be placed after, for example, impella is placed, is going to be for long-term or short-term, that actually has a great impact. Because as you can see, our sticks as an interventionalist are far more lateral. And that has got its own real problems. Of course, it can be slightly easily compressible, but the challenge is that you can actually hurt the nerves if your arm remains extended over a long period of time. And I think getting a surgical conduit in many situations can be the right approach. So I do not want to take too much time. I've exactly spent 3 minutes, but the 3 challenges that I want all you to think about when you plan access with large caliber sheets is to think about how to deal with calcified iliac arteries and know certain basic devices that you can bail yourself out with. Number 1, I can tell you that most commonly used wire-bound stents go over an 018 wire. So if you end up in trouble, you have a 035 wire, those 1.5 minutes of exchanging that guide wire can be the difference between success and failure. Second, if you are trying a non-traditional access, planning those cases well with imaging and with a surgeon are absolutely very important. Common femoral interventions with or without stenting, atherectomy, other attributes need to take into account how it is going to compromise profunda flow, and if you put a large bore sheath, how are you going to antegrade, perfuse the limb, and what are the signs and symptoms you can do it, both in the cath lab or at a later stage. So I'll leave you there. Enjoy your lunch. And of course, we have an expert panel in this room and also outside it. I hope you're enjoying CVI. I look forward to this forum to grow and flourish. I hope this format is going to be engaging. Last final point, that when you go over the schedules, do flip over to page 8 and 9. Those are our executive board members who have contributed extensive amount of time to plan out and curate the topics. And hopefully you will have an opportunity to talk with them and share your views about both the venue and also the conduct of the meeting.